Our next speaker is Dr. Sherry Thomas, who will be speaking to us today about vaginal health and vaginal improvement. She comes to us today from Agoura Hills, California, and she has a very interesting background. Dr. Thomas has a master's in public health. She then actually became board certified in obstetrics and gynecology, and then actually broke into a new field. She was one of the first physicians to be boarded in the subspecialty field of female pelvic reconstruction medicine. And she actually was one of the pioneers, starting with her subspecialty boarding in 2013. Her traditional training has led her to the passion of treating patients with pelvic organ prolapse or vaginal hernias, with the management of urinary incontinence, fecal incontinence, anal incontinence, and also mesh graft complications. She works with vaginal fistulas and other very serious pelvic floor conditions. Yet today, she will not be talking to us specifically about vaginal hernias and surgical complications per se, but she'll be talking to us in a more global manner. She'll actually talk to us about the use of energy-based devices, specifically lasers and radiofrequency, for the treatment of vaginas and for vaginal rejuvenation. Dr. Thomas, thank you and welcome.
Yeah, thank you. Thank you. Do you have the AV guy here? I want to make sure my correct slides are loaded. Nobody's been here. He's not here. He hasn't been here for an hour. We're on autopilot back there. Hi, welcome everybody. Thank you for having me. And I want to thank the A4M. This is my first lecture here, and I'm very excited. Good, fun stuff. Stick around. I like the last talk about the Y-lift. We're going to be talking about that for the pelvic floor. And all of you out there know your female clients are asking for this. They want it, and everybody's very concerned about the FDA. I'm going to go over that. Let me see if my slides will come up. If not, I'll just, back in the day we could pass them around. Now we can, I'm not even up. You know, I think Laura's outside if you want to. Let me see if I can play with this and get this going. Are you the AV guy? Are you what? Oh, thanks. So, good, here he is. So anyways, my background, I am a OBGYN, I am fellowship trained in female pelvic medicine and reconstructive surgery. I spent more than 20 years doing mostly pelvic surgery, and I'm here to tell you that non-surgical treatment of the pelvic floor is what women want and what I think all of you can bring them. And the reason you can is because the OB-GYNs are not listening to this field, and that's a big problem. A little bit more of my background, I am a big researcher. I actually say I'm not an aesthetics doctor. I spend 75 to 80% of my time, thank you very much. Is this the pointer here? To the right. I spend 75% of my time doing research. I have 5 FDA studies. I'll show you on my disclosure. Let's see, here we go. Where's my disclosure? Why is my disclosure slides not come up? Anyways, I spend 80% of my time doing FDA studies. These are class 3 devices, and I also do 2 biologics. Yes, we have a minus 80-degree freezer, so I understand your world really well. And everything I tell you about lasers and radiofrequency is actually off-label, but I'm going to show you our clinical trials on it because I'm doing 2 clinical trials right now. We have 2 more that we're putting in on histology. So by a show of hands, how many people here are physicians? Okay, about half of the room. Nurses? Nurse practitioners, PAs, okay. And then how many people here are estheticians and do other work in this area? Great. Spa owners, a few of you guys. Okay, is anybody here from the FDA? No, seriously. Yeah, raise your hand if you are. I'd love to meet and talk to you afterwards because we just had our not-for-cause audit from the FDA for one of my class 3 devices, and we came through with the flying colors. And, you know, it's good that we work with them. So I have no problem if they are. So these are my objectives, and I'm going to talk about why you need to do these. It is what patients are asking for, and they're going elsewhere. And many of you know as physicians, I've spent my life in the operating room. I work on the Da Vinci. But a lot of these can be done by nurse practitioners, the lasers in California and in Las Vegas. I think anybody can use a laser. Radio frequency doesn't really need anything other than a medical assistant. Of course, you need to supervise. Of course, you need to evaluate the patients first. But these are delegations of your job that can be done in your office while you're in the office doing other things. And patients are asking for them. So let's just cover the big elephant in the room, the FDA, right? And what they came down with was this. And I'll tell you right now, I have every single company out there, almost every, has asked me to work with them, and I don't. I collaborate with a very small company, and basically they never asked to see my data. The studies I am going to show you, I have actually written myself and designed them. And so what I'm telling you about is stuff I've done. But this is what the FDA said: deceptive marketing. The serious side effects are unknown, and unproven treatments. And what happens is this: if you're going to start using a new product and you're in the world where we're using a lot of new things, it's cutting edge, right? You really need to do a clinical trial. What does the FDA care about? Informed consent. That you're doing something that's off-label. It's okay. We're physicians. The FDA, which should be the FDDA, the Food, Drug, and Device Administration, they don't practice the way, they don't tell us how to practice medicine as a physician. They just talk about the devices. So we use medications, devices, we use things all the time that are off-label, and we need to tell our patients that. And that was the problem that was going on. People were not telling their patients, please don't videotape me. You can take pictures, but don't videotape me. You can take all the pictures you want, but please don't videotape this. I'm happy to talk to you afterwards. So that's what they didn't want, was the deceptive marketing. Botox may improve wrinkles, right? Nobody says it does. We use a lot of medications that work well, and we use them off-label. But we absolutely tell our patients, same thing with these devices, and I don't have a problem with that. So all these companies, Thermiva, the Mona Lisa, Cyton, BTL, they were all notified, and many of them have pulled their devices or modified them because they had no 510K approval, and they were making claims that they just shouldn't have made. These devices are actually approved to coagulate tissue. That's what a Bovie does. And the lasers are approved to destroy tissue. That's what a laser does. But we're using them off-label to do other things. That's okay. We're physicians. We have a medical license, and we can practice medicine just the way we want to. But we have to be very realistic as what we're doing. So, lasers and radiofrequency, they are not approved to do vaginal dryness. They're not FDA approved to treat incontinence. They're not approved to treat vaginal laxity. Do they work? Yes, I think they benefit. I have statistically significant data I'm going to show you at the end. And I think that you need to understand which device you're buying when you buy a device. And not every device is the same. And yes, those marketing people will tell you anything to sell you a machine, but really ask them, what's the 510K approval? I know you changed this to a really fun handpiece to put in the vagina, but is it 510K approved? And two, what is it going to do? Are you going to stand behind it? And that's what's so important. So, also we use lasers and radiofrequency together in the vagina. We use them together in the face. Why not? Works well. So when we talk to patients about lasers or radiofrequency, we want to know their symptoms. What kind of symptoms are they having? And that determines whether I'm going to use a laser or a radiofrequency. What are their physical findings? Yeah, we're physicians, we're nurse practitioners, we're PAs. These patients should be examined before we just say, hey, we're going to give this seminar on lasers and let's just collect money and treat you. I don't even know that they don't just have some simple bladder infection causing their pain, right, without examining them. And that's some of the problem that the FDA had, is you can't just sell a product to treat something when you don't really even know what the patient has. And then the patient's expectations. For those of you that are surgeons in here, you know that some patients come in, they want a little V-lift, Botox filler. No, what they really want is a facelift. Or they want their tummy tightened a little. No, they really want a big tummy tuck. And you know better than most gynecologist patient's expectations. That's like key to your practice. You need to know that beforehand. So what's the difference here? Well, I think lasers have been used on the face for years. They help vaginal dryness. They help painful sexual activity. But remember, they don't go much more than 1 millimeter, right? You'd have to stack a superpulse laser to 10 to get down past 1 millimeter. And so they're not going to really help laxity. They're not going to tighten things, and we know that from the face, and that's why We started using radiofrequency on the face with bulk heating to stimulate the fibroblasts and get that elastin and collagen 1 going. So if they're not going to really go more than 1 millimeter, how are they going to tighten up the periurethral tissue for somebody who has urinary incontinence? They're really not going to do that well. And that's why these particular companies started having so many problems, I think. So what are we doing? This is a picture of the vaginal epithelium. This is from Lila Nightingale, over 20 years ago. And this I took from a, let me go back here. Sorry, I'm trying to find my pointer. Is that it? No, I just turned it off. Which one's the pointer? Where's my guy? Hey, is he here? Thanks. Okay. Pointer. No, now let me go forward. Okay, I can work a $2 million Da Vinci, but I'm having problems with this. So the epithelium right here, this is the epidermis, the dermis. You can see what she did is she gave this patient estrogen, and 6 weeks later she took a biopsy. This is what we're trying to do with the laser, and it works really well. But very few of the laser companies have actually shown us any of this data. This is what we're looking for. And this is actually the future of some of what I'm doing with a super pulse laser I'm using. We're showing histology on that. So what do I use? I just use a simple CO2 laser, but I have a super pulse on there. So I can really deliver the energy much deeper. If you think about the laser, you have continuous wave and super pulse, and they make a difference. In the vagina, vaginal epithelium is between 1 and 4 millimeters. The face, you're under 1 millimeter. So I'm going to deliver more energy. I'm going to stack it because the vagina is a little bit more rugged than the face. Remember the face back when you were just doing totally ablative lasers? That's why everybody finally went to the fractional so that you could just deliver a percentage. I'm delivering fractional laser, but I'm going to use a super pulse. And these are the settings, 30 watt. And so if we think about delivering energy, there's two things we want to know. How much power are we delivering and over what period of time? And that determines our energy source. And if we look at something like the peak power, this is like cooking a steak, right? If I put a steak on a fire that's really hot, I can sear it on either side. A continuous wave, I'm cooking it slowly. So I'm going to get more char on this tissue if I use a continuous wave. And so if you're going to buy a laser for the vagina, make sure you buy something that has this peak pulse so that you can really deliver it deeper and you can get no char around it. This is what it looks like. And actually, this is what it looks like on a piece of paper. So this is the difference in the different lasers out there. When you wonder which laser should I use in the vagina, ask them for a super pulse. I can tell you that now, why isn't this advancing? How about this? Where's my AV guy when I need him? Hey, my slides aren't advancing. Anybody here from AV? Laura? Laura here? Where's Laura when I need her? Okay. Anybody here know AV enough? Let me see if I can work this again. Wow. Let me see. Okay, I'll advance it here. There we go. Yay. Okay, so if I'm using just a continuous wave, I'm going to have a crater. If I use a super pulse, and this one's stacked to 10, you could only do this in the vagina. You absolutely can't do this on the face. And this is what happens several days later in the vagina. We want to thicken this epithelium. And what we're actually going to do is we're going to start showing you histology of that with the super pulse I'm using. So let me tell you about a clinical trial with the laser. We've just finished the 30 patients, but this is just an analysis of 24 of those patients. I gave this at ASLMS, the American Society of Lasers in Science and Medicine. And our primary objective is what? Female sexual dysfunction, right? This is a well-tested questionnaire. Now, unlike your world where everybody can look at faces, and I saw a lot of pre and post faces, I'm not going to show you pre and post vaginas because the proof is in how the patients feel. And this has 6 domains. It's going to tell us arousal, desire, lubrication, and things like pain. We're also going to look at urinary incontinence as secondary outcomes because people said, hey, lasers help urinary incontinence. Okay, I'll throw those questionnaires in there. Remember, I'm a researcher. I know how to do research. I'm going to look at other outcomes. And I'm also going to make sure they're consented. They know that this is off-label, that I'm looking to see how this improves these symptoms. And I'm going to make sure, what does the FDA care about? 2 things, consent and side effects. They don't care that our devices we're using work or not. They know that we'll figure that out. So the demographics of these first 24 women were a little older. They were all menopausal. They all had vaginal dryness. They all had significant pain. And they were mostly white women. These are the settings. We're not giving them a lot of energy, 1.6% density, 17.3 joules per centimeter square. We do 3 passes. Once you put this inside the hymeneal ring, there is no pain. How many people in here use lasers or radiofrequency in the vagina? Okay, a lot of you. Once you hit the hymeneal ring, boy, you better have some numbing medicine and cream on that because they're going to be painful. And I give them lidocaine to go home with. For radiofrequency, and we'll get to that, you really don't need any numbing medicine at all. And that's why we do 3 passes, because and I've tried to turn up the energy more and give them more just instead of doing all 3 passes, and they can't tolerate the actual discomfort. So, again, we do the FSFI, the 6 domains, sexual desire, arousal, lubrication, all of these. Within the first 14, and this is actually 22 patients, all of these were statistically significant. I was surprised. I mean, I could have just stopped the study there, but everybody likes to see 30 patients, so I kept it going. Of course, if we look over here on the lubrication, we better hit a home run because that's what we're looking at, and also on the pain scale. But all of these, what was really shocking to me is these pharmaceutical companies spend millions of dollars trying to get a medication for women that increases desire and arousal, right? Because desire for us is pretty important, and that's what we lose as we age. And this actually improved desire. Shocking to me, but really informative. So we look at the patients. Everybody started with what we call sexual dysfunction, and you can see they all improved. The one patient that didn't get above 26.5 actually had interstitial cystitis, and so she'd always had pelvic pain, and she was so happy. She says, I'm sexually active now. I'm really enjoying this. These patients have stopped sexual activity before they come to see you because they cannot tolerate the pain, the burning, the bleeding, the discomfort, the tissue they have. They're thin menopausal women. They're menopausal women with very thin skin. And it is so discomforting, they've just given up. And many of them have lost their partners as a result of it. Again, this is the desire domain singularly. Shocking to me that they improved so well on the arousal. All of these were statistically significant. This is non-parametric data with a paired t-test. So the adverse events, this is what the FDA wants to see. You've got to say how many people are having pain, how many people get bladder infections, and you can set that yourself. One of my FDA studies says bladder infections are within 7 days, another one says 10 days. It depends on how your study's written, and they don't really even care how you write your study. You just have to follow the parameters within how you write the study. And you need to put that in. You need to be with an IRB, just a few little simple things. So this is the first study in the United States that showed a superpulse laser statistically significant in all domains. If you look at Mona Lisa that published their paper, they had 30 patients, but they couldn't even show each domain. They barely got their patients over 26. Our patients were well beyond 26 and in each domain. They had to put out a bunch of other criteria to just publish their paper. And again, their handpiece is not 510K approved, oh, by the way. So let's talk about radiofrequency. Remember, we said lasers are superficial, dryness, and painful sexual activity. But what happens if you have vaginal laxity, right? I want to go a little deeper with my energy. So I'm going to use a radiofrequency. And what is a radiofrequency? It's the Bovie. We've been using it for over 50 years. But what do we do in aesthetics? We actually fan that heat out, and we try to deliver bulk heating. And unfortunately, most of the devices you look at, this is what we've all used for years that are surgeons, but most of the devices you look at have this flat metal tip, and as a result, you have to move it around, otherwise it's going to get too hot. This actually comes off of a Thermiva probe, and if you don't move it, and you lift it up, you can arc. Now, there's a lot of changes you can make that don't do that, and I'll show you those. And no, you don't have to freeze it first to then deliver radiofrequency. That makes no sense to me at all. This is another one when they said, oh, we'll go in 360, but they still have to move it in and out because it's a bare metal surface, right? Just like our Bovie. And that's kind of like drawing on a board. If I'm trying to deliver radiofrequency and I draw on a board, I'm going to miss a lot of areas. And if I have, and some of these devices have temperature feedback turn off. Okay, so that means when I get to this, where it's nice and hot, it's going to turn off, but now I'm over in the white area and I'm not going to get any radio frequency. Makes absolutely no sense, and that's why these patients aren't getting enough radio frequency, and you really don't know how much you're delivering, heat you're delivering. So let's take what we do in laser. Let's do a grid system that has a matrix on it. And then this orange coating over your bare metal tip is it's a plastic, it's a polyamide coating. They actually use it in NASA to disperse heat. So what that allows you to do is actually deliver this entire 1.5 by 1.5 centimeter area of heat. And guess what? You don't have to move it. And you don't have to move it because now instead of using heat feedback, we're going to use impedance feedback. So this grid right here will evenly deliver heat without moving it. You can see this is done on a piece of chicken where they heated it too much. I don't think you'd want to do that on your face. Using a 6 megahertz generator, so you can get up to 200 watts. Remember when Thermiva came out, there was a 20-watt machine. They go, oh, we'll give you more, we'll do 80. That's fine, but each one of those companies is going to have to tell me what that particular amount of heat is generating in the tissue so that I understand what my objective results are. And then again, this really nice coating, this polyamide coating that is used by NASA to help evenly disperse the energy. And then we're going to have an impedance, live impedance feedback. So you're going to measure the impedance because you've got this monopolar feedback on the back of the patient. And it's going to feed back, and then it'll give you RF emission. If you do multiple times, you can actually change how much you deliver over time. Because as you get more radio frequency, your impedance changes and you can stop delivering energy. So you will not burn this patient. And I've actually put little temperature probes on the end of this to monitor it. And yes, we get in the vagina, I get about between 43 and 45 degrees. And on the outside, I use a little heat camera, and I can see the outside what I'm treating. Now remember, when you're treating outside, for those of you that do vaginal and gynecologic applications of laser and radio frequency, you know the outside, and especially the labia minora, is like treating periorbital. You can't get that too hot, it hurts. Yeah, you're shaking yes because you've been there. And then you get to the labia majora and the whole pelvic floor, and you can actually warm it up to 44, 45 without, and every patient's a little variable, but all of us know the more heat you can deliver, the better results you're going to get, right? So if I have an live impedance feedback, as I start getting some heat here, instead of it turning off, it just decreases the amount of energy I'm going to give over time. Or once I've given enough, it turns it off. And you can hear it in the machine. It's really lovely. So you don't have to move it around. And then the other thing is you don't have to burn your shoulder out either. I actually had one of those metal devices. One of my poor medical assistants had to go on 2 weeks leave of absence because her shoulder burned out. And then just hook it up to the radio frequency machine, and you can deliver whatever you want. Again, maximum amount of 200 watts. And yes, I use 200 watts in the vagina. It works well. And so what we're treating is we're going to treat this entire area. And unlike some of the companies that say, oh, here, let's just treat the hymenilla ring. Really? That's what hurts. I try to stay off of that. I don't want my patient to think this is painful. So I treat the entire pelvic floor because remember, the pelvic floor muscle gives off the urethra sphincter. So I want to increase the tone of that, the collagen elastin of my urethra and my rectal sphincter, especially if we have a little fecal incontinence too. And I want to treat right inside the vagina, and I treat right under the urethra. And I know some of the companies say don't treat under the urethra. Why? That's what I want to deliver energy to. And no, I'm not going to cause a fistula. I'm not going to cause a burn because I have impedance feedback there. So if a patient, this is a sagittal section of the pelvic floor, symphysis pubis, this patient has a little bit of a cystocele, and that would be fine to treat. This patient's right getting to the opening. You now starting to get a little bit bigger, but certainly this patient whose uterus is hanging down, you're not going to treat with anything other than surgery. So you really do have to examine your patients, and you have to understand what the patients think. This patient, again, with the uterus, this is a cervix hanging out of the vagina. Yeah, none of these minimally invasive techniques are going to work. So this is let me go back. This is a registered clinical trial. If you don't want to write this down, you can Google my name on clinicaltrials.gov, and my studies will come up. You can see them. A primary objective was just severity of laxity, with patients tell us how severe they are, moderate, mild, severe. And then I looked at other sexual dysfunction. But remember, patients with vaginal laxity are still sexually active because they're just too loose. They're just not enjoying it. But they're still able to be sexually active. We also threw some other secondary things in, like fecal incontinence, just because we know that's such a big problem now. And, of course, the urinary incontinence with the questionnaires I use on my big FDA studies, the UDI, IIQ. And these are the questions we asked them about the vagina. This is really pretty closely related to the degree of prolapse, grade 1, 2, or 3 prolapse. Again, we asked the FSFI, which is so well-tested. I just used the well-tested questionnaires that are out there. No sense of making up my own. I've been doing this over 20 years. All those researchers have done a great job already. So the demographics of the 30 women, this is 14 patient sub-analysis. I'll be presenting the 30 patients total at ASLMS this April or March, I think. And most of these, half of them, a little over half, were premenopausal, and 5 were postmenopausal. So your patients that want radiofrequency are the women that have delivered recently, they have some laxity, and they really need to be tightened up. But most of them are going to be sexually active, or they have urinary incontinence. This is the vaginal laxity questionnaire, and you can see we statistically significant on all patients, and that was the inclusion criteria. They had to have vaginal laxity. When we looked at their urinary incontinence, you can see this is a urological distress inventory. They are giving me, all these people have incontinence, and you can see a statistically significant improvement. This lady right here had asthma, and one day I sent her out of my office saying, "You've got to get on steroids. You're going to die if you don't get your asthma under control." Yeah, she had bigger problems. The quality of life questionnaire, they basically say if they have to live with incontinence the rest of their life, how would they? The 7 to 10 say, "I'm not." And you can see all of these people improve, statistically significant. The patients that qualified for sexual dysfunction, sorry about that, let me go back. The total scores, those patients, not all of them had sexual dysfunction, so some of them were already above 26. And these patients also improved on both desire and arousal. The other domains they didn't, but again, it's only 14 patients. And I think that once I get to 30 patients, I'm going to see an improvement in things like lubrication. So sexual satisfaction, this is a simple one. I just ask people this all the time if I'm not doing a study. How improved are you? These guys are already happy, but these guys are improving here in their sexual satisfaction. Adverse events, you absolutely have to report those. A few bladder infections. I had one patient call me 2 days later and said, "Dr. Thomas, you burned my labia." I said, "Great, come on in, let me see you." She actually had an ulcer that I cultured for genital herpes and did a blood test. She'd never had a history of it before. So yes, I put every single one of these patients before laser or radiofrequency on an antiviral, and that has a history of it. I don't put everybody that doesn't have a history, but it's pretty uncommon. You're going to have a patient that gets that. Now, why do we want to do clinical trials, and why are all these companies in so much trouble? Because they just said, "Oh, my instrument treats urinary incontinence. It treats atrophic vaginitis. It treats this. It treats that." No, you can't say that. Remember, this data I'm showing you today is off-label, but I believe it works. And I'm willing to sponsor a clinical trial, and I'm actually willing to show you that data. And that's what's so important. And each single company has to do that with the specific settings on their laser or radio frequency. They can't just say, "Well, Sherry Thomas used her laser, and so our laser works all the same." No, it doesn't. I love being the gold standard, but no, it doesn't. And you have to follow good clinical practice. When the FDA was in my office, they went through my consents first. And some of these studies, I think I have 14 consent changes in one of my class 3 devices. And one of the patients, as you know, some of you sign your signature different every time. They questioned us for 2 hours on the difference in her signature. I mean, we were about ready to have her come in and talk to the FDA and say, "No, I sign my name differently every single time." That is how much they want those consents. Yeah, they care. And so you have to follow them. You also have to have IRB approval because my data is actually registered. I have to keep my records for 10 years. This is the real thing. I'm not just giving you marketing data and saying, and these patients actually exist. I have hard copy data on these patients. This isn't just some marketing thing that, oh, why don't you try this? Also, if you want to get into a peer-reviewed journal, and actually I see a lot of stuff that's in peer-reviewed journal that's not registered, but this is the future. If you're going to get in peer-reviewed journals, you really should be registered, and you really have to follow IRB protocol. This was the radio frequency devices. Most of these are off the market right now. Of the two I mentioned, the Matrix is the Nuviva right here. Jeff Kinkle, if you know him, he's a plastic surgeon. He's actually doing, thank goodness, a sham-controlled trial with our Matrix radio frequency head, and I hope to see that data out soon. This company's pulled their radio frequency. This company's not marketing theirs anymore. All these guys, Viviv has one, but all their studies were done outside the United States. And the gentleman that presents all the time actually never did a patient. I can tell you I've done all these patients. I can tell you their side effects and how it works. I've done the studies. So what's the future to this? We have to show histology, collagen, elastin. We're doing transvaginal vaginal thickness, and that's kind of fun because I think on the face, that's why we see the difference. How do patients respond? Why do patients respond differently? Why does a 70-year-old respond so well with radio frequency and a 30-year-old doesn't? I think it's the thickness you start with to begin with. So we're registering that and measuring it pre and post, and you'll see some of that in the future. So, I think that we have to be careful on all of these devices. I think they work great. I recommend if you're using them that you actually learn how to use them as a physician first before you have your nurse practitioner, your PA sit down and do it. And show them how to do it. Because if you're not getting results, I'm going to tell you, it's in the technique. And not all these companies have the same instruments. And most importantly, oops, sorry about that, hitting that. Most importantly, you're missing these patients. You have female patients in your office every day. Don't let them walk out the door when they ask about this. I am an OB-GYN. I'm actually, board certified in female pelvic medicine and reconstructive surgery. My colleagues are just missing out on this totally. Now, some of it's twofold. Some of it's because they only know how to bill for procedures. You guys know our fee-for-service. You know how to collect money up front, so that's easy. But two, I think some of the negative stuff that's come out by the FDA, they don't quite understand it. I think this room, most of you in here understand off-label better than the common OB-GYN does. And just be careful when you're using it, that you tell them it's off-label, but you think it works. Botox, isn't it still off-label? I mean, seriously. I don't think that stopped Allergan any. So if you guys want to talk to me, I'm going to be at the Perigee booth. That is booth 3086. I will be there all tomorrow. I will be there later on today. And if you want to go, I think we're going to have a little group at the, where is it going to be, Jim? The Yard House? If you want to come by later for drinks and, what's it called? Public House. The Public House. So here, as you take a picture, if you want to stay in touch, please be my guest. You can call me. You can come. I teach every Friday. You can come watch how these procedures are done. You can go on to Instagram, put some stuff up there. I think if you want a copy of that slide, the Venn diagram, I can put that back up if you didn't take a picture of it. Everybody got that? So, do I get questions now? No? I do? Good. How many minutes do I have for questions? 10 minutes. Great. Okay, let's have some questions. I'll rephrase it since you don't have microphones. Yes, please.
How do you compare this treatment to surgical treatment of the vagina? How do you compare, Jim Pesos, plastic surgeon from Dayton, Ohio, how do you compare this kind of treatment to surgical repair and tightening of the vagina?
Excellent question. How do I compare this to surgical treatment? Well, since I've done surgery for 25 years, and the lady with the vagina falling out, I still do surgery on that. I was just on the Da Vinci on Monday. But I think patients who have prolapse just to the introitus, really will benefit from this or may benefit from this. The problem is just like the face, you can't predict who will benefit and who won't. But having had multiple surgical procedures myself, I did everything I could non-surgically first. So that's some of the problem. I can't give a prediction. Now, once my study's out, you can tell a patient based on if you're within this age range, and I have patients in their 80s, but within this age range, with this particular device and these treatment parameters, these are the results that you may see. But again, think about surgery. I mean, I've been a surgeon all my life. I'm in the Los Angeles area where most of what I do is redos. So if you've had a pelvic prolapse surgery or urinary incontinence, you'll get my name. And those surgeries, just like your hip replacement or knee replacement, those don't last, So do you have to redo these? You bet you do, because we keep you aging. So I don't think even surgery is a cure, and it sure has a whole lot less side effects. Great question. Yes, here. Great question. Hormone therapy in conjunction with this. Yes, all my patients, and I didn't mention that, have had hormone therapy. There's a very big problem in the female vaginal epithelium that when you hit about 60 years old, if you haven't been using estrogen up to then, the vaginal epithelium becomes so atrophic, it doesn't respond to heat. It doesn't respond to estrogen. Inside the hymenal ring is where your estrogen receptors are. So I'd love for all those women to have started vaginal estrogen, not systemic, because that's not really hitting the vagina, before that time. And my patients in their 70s, once they get to 70, wow, I was kicking rocks with so many of these patients when I got the laser. And I didn't believe it was as good as it was at first. So when I got the laser, I'll be right with you, I thought, well, let's see what this does. And it did so well. I just called him up. I said, you will not believe, but I got something for you. And I have so many of those patients over 70 now, but I could not wake up the vagina with massive amounts of estrogen inside it. Great question. Yes?
All the product representatives say that their device works for every gynecologic problem, whether it be radio frequency or laser. If I could only buy one machine, what would you recommend and why?
Oh, that's a great question. One machine. Well, as I showed you with the Venn diagram, I think you need both. If you mostly see menopausal patients, use the laser. And all of you can also use the laser on the face. And it's a super pulse. I've seen that laser on the face. It's phenomenal. Ron Moy uses it. He loves it. And for younger patients, I think when women deliver, wow, the vagina, it takes a good 6 months for the vagina to go back to normal after giving birth to 10 centimeters. That's like pushing a bowling ball through the vagina. For the women in here that have kids, you know what that's about. So if you have mostly a younger patient population, buy the radio frequency. I think the prices are going to become more competitive, and I think that you'll see that you can should be able to buy both pretty soon for a pretty reasonable cost. Great question. Yes, next, please.
Do you use Emsella BTL chair as well in conjunction?
So the magnetic chair, right now there's only one company that has it, BTL. We have over 100 years of data on the magnet it's a skeletal muscle contractor. It depolarizes the muscle. Hold that thought. You're going to see many of those out there. And again, the problem I have is the magnet, it's a 2.5 to 3 Tesla magnet. It contracts muscles because I can't contract them myself. It's been used in physical therapy for years for muscle atrophy. And I think that is the future. We have a lot of data from the past. Here in the United States, we actually had two devices that were 510K approved over 20 years ago, and they fell out of favor. And some of the problem people say to me, well, you have to keep doing it. Yeah, well, I have to keep doing everything all day. I keep using my moisturizer and creams on my face, too. I can't stop. So hold that thought. I think you'll see it for muscles. It may be a benefit, but there is zero data on the BTL. That thing came out of Europe. I'm looking for some of their data. The data that you see in the United States was 20 years ago on a different machine. So again, every single company is going to have to show that. And how many hertz are you using? At what power? Over what period of time? And what patient parameters? Are these patients with severe urinary incontinence? Mild, moderate? Have you differentiated urge or stress? I mean, that's the problem the FDA is going to have with a lot of these claims. Yes.
Have you tried the O-shot or PRP injections in conjunction with what you're doing?
So the question is, do we use growth factors? I think growth factors in the epithelium are great. The O-shot is a certain person's idea of how to put PRP into right under the urethra. That's where some women have a sexual response. I think we're going to see a lot of different growth factors in the vagina. In terms of using my own, I'm pretty old. I'd rather use some young kids' growth factors rather than mine. I'm just saying. So I think that the future is we have about 5 different growth factors right now that are approved as over-the-counter. You don't even have to write a prescription for them. So that's great, but let me see each one of those in the vagina and let me see the response, let me see the histology, let me see the vaginal thickening. In the meantime, what are we really treating? Great question. Yes?
Okay, Dan Rich from California. You mentioned about using estrogen, to treat the patients. Do you do this routinely prior to doing the laser?
So,
Vaginal estrogen.
Vaginal estrogen in conjunction with their systemic, yes. If they'll take it, if they've had ER positive breast cancer, they don't, or melanoma or something that you would absolutely not give estrogen with. So yes, I've tried, and most of them have tried to take it too. It just doesn't work. And then the other silly thing people do is they throw away the applicators and tell them to put it on the outside. But I'm sorry, yeah, thank you. I'm sorry, and gynecologists do this all the time, and I'm sorry, there is no estrogen receptor positive tissue on the outside of the hymenal ring. It's just a waste, and that's why it doesn't work. So some people just haven't used it correctly. But once you hit about 60 and you haven't used vaginal estrogen for about 10 years, you get to a point of atrophy, you just can't wake up that tissue. Yeah, other questions? Yes? That's a great question. Do I recommend yearly treatments? Well, I've had my laser for 3.5 years. And the patients, I brought in about 15, 16 patients the first 2 days and just ran them right through to treat them. The patients that are under 60 that responded really well, I'd call them every year when I'd have I'd train people or just to say, hey, how's it going? Do you want another treatment? And they'd say, no, I'm fine. Like, okay, the second year, no, I'm fine. I'm like, okay, call me when you need another treatment. For people who are on anti-estrogens, Arimidex, tamoxifen, things like that, they generally do need a follow-up at the end of a year. The other problem I see is if you have an older patient, I have to turn down the power a little bit to deliver the energy. So what I do is I wait between the 3rd treatment, I treat every month, or sometimes 6 weeks if they're older. I'll turn down the energy, and then I'll wait 3 months to do a 4th treatment, and at the end of 3 months, and I've never had to do a 5th. Just because you're treating such a thin epithelium, but that's a great question. And once you treat an older patient who's not on an anti-estrogen, they don't usually need a follow-up in a year or 2. It's the anti-estrogens that are just killing that vaginal epithelium. Yeah, great question. Yes, Jim. Oh, charge for treatment. So I'm not in Beverly Hills. Beverly Hills is charging $4,500. That's $1,500 per treatment. I charge $3,000, which is $1,000 per treatment. And as I said, radio frequency, you can have a medical assistant do it. The laser, you have a nurse do it. And patients they walk in and they're very happy to pay it. I got to tell you, I don't know why I go to the operating room anymore to do surgery. I spend an hour or 2 to 3 doing a Da Vinci sacrocolpoplexy. It's probably our most complex procedure. And I can stay in the office and do this all day. It's easy. Yes? So what's my follow-up time? Yes, I've had the laser 3.5 years. That's true. There's no long-term data. And the radio frequency about 2, at least this particular matrix radio frequency. So my follow-up time is 3.5 years on the laser and 2 on the matrix. I give every patient my telephone number after I do a procedure. I've done it for surgery, and I've done it for this. 1, I didn't believe it was that effective, and 2, I just didn't know what was going to happen way back 3.5 years ago. And I tell them, just call me, text me tomorrow, and if you have any questions, call me, I want to know. So I have a long-term follow-up, no contractures whatsoever. No, I don't see contractures. But again, I'm delivering this energy, and I can control it. There is not one dummy button on this equipment I showed you. You get to decide how much energy to deliver. That's one of the biggest things that kills me on a lot of these instruments is, oh, push this button or that button. You guys are much smarter than that. You guys have been delivering energy for years. It's insulting to my intelligence to be given a dummy button. So, no, I don't have contractures. I don't have burns. You know, I get a few bladder infections, a few yeast infections. You're delivering energy to the pelvic floor. And, yes, that's what the FDA wants. They want long-term follow-up. So, yeah, I'll probably keep my studies. The adverse events, I'm required to keep my records for 10 years versus the regular 7 for patients. Yes? What is the contraindication? Contraindication. Well, certainly I treat all the active infections. I mean, I evaluate the patients first. I make sure they don't have a bladder infection. If they have a bladder infection and you treat them, actually they can't tolerate the heat. You'll end up stopping it. So contraindications are patients that have bladder infections or other sources of infections. If they've had herpes, I want to get that herpes under control. I'm not going to treat active herpes. But other than that, there's very few, contraindications to delivering laser or radio frequency to the pelvic floor. Yes? How do I space it? Well, first of all, I've got to, because I have patients that come in and say, I'm dry, but I have laxity. And I say to them, okay, what is the biggest one you have? So I always treat what bothers them the most, because sometimes they say they're pretty equal. You can deliver the radio frequency and then do a laser. You can't do the laser and then deliver radio frequency, because you get a little bit of a discharge for a few days. So generally, I just treat with one and then wait for about a month or two after the third treatment to see if I'm going to do another treatment. And rarely do you need the other treatment, because what I'm finding from the radio frequency is I'm actually getting a little bit of lubrication from that. So, it's really about patient symptoms and what they want. Yes? No, that's the beauty. They do not. This is all fee for service. This is why the gynecologists don't understand what to do. Yes. Yes, in the back. Hi. Well, yes, that's a good question. If somebody has urinary incontinence, do I adjust it? Yeah, I'm going to give it a little more heat right under the urethra. Versus if they have fecal incontinence, I'm going to give a little more heat and posterior in that area. So I spend a little bit more time in those areas, absolutely. But the radio frequency, because I don't have dummy buttons, I'm adjusting anyway. But I go to the full 200 watts inside the vagina and do about 10 minutes in there. Good question. Great questions. Well, you have my number. Please feel free to call me. Come later. I'll be at the booth. I'd love to hear from all of you, and thank you.